Thanks, Nin, and thanks for the opportunity to speak here today. These are my disclosures, none of which are particularly relevant for this talk. So this is a problem, one of the dreaded things we see that can be a long-term complication after gastric bypass surgery. These patients can present with a variety of symptoms and can be one of the banes of our existence with these patients and their management. There are some risk factors that are involved with ulcers. These are some of the things that we actually counsel our patients about pre-op and may do some screening and actually subject different options if these are some of the things they can't get rid of, such as smoking. And this is one for all of my patients. I will try to have them stop smoking before bariatric surgery. But if I think they're at high risk for recurrence, I might actually sway them away from gastric bypass. Non-steroidal medications, again, are something you can screen pre-op if somebody comes with a lot of joint pain, or if they have heart disease and they're needing to take chronic aspirin, that may be a reason not to do a gastric bypass. But we also will counsel the patients that Tylenol is probably the best pain management that they can have long-term after bypass surgery. There's mixed data on H. pylori infection, but that is also something you can screen for in these patients. There's also some indication that alcohol, stress, and even chronic anticoagulation could be an issue. Prevention also can be helpful in some of the things that you can do at the time of surgery by creating smaller pouches. More stomach leads to more acid and potentially more ulcers. There's also potentially suture issues, so I always use absorbable suture. And I also continue them on a PPI after surgery to try to minimize any effects with ulcer formation. Gastro-gastric fistula can also be something you see with or without marginal ulcer. It's present in about 19% of patients with marginal ulcer. There's a question if it's cause versus effect. Did a perforated marginal ulcer cause that gastro-gastric fistula? Or potentially are you having acid refluxing into the pouch from an ulcer that leads to jejunal irritation? Not clear, but there's definitely some association. If you find a gastro-gastric fistula, it's not necessarily a reason to do surgery, but it also may be a reason that you can if you have inadequate weight loss or if you have some chronic ulcer. How do the marginal ulcer patients present? Pain in about 67%, perforation in an unusual series, but can also present with bleeding, obstruction from adhesions from the ulcer, dysphagia, nauseating, vomiting, but some of these can just be found asymptomatic at a follow-up screening endoscopy. Diagnosis, best diagnosis is going to be with an endoscopy, but you can also find them with perforation on a CT scan or based on just symptoms of acute abdomen, can be found in post-op patients with just epigastric symptoms in general, and are at least 3 months after surgery, so this is definitely one of the long-term problems that we see with bypass patients. Variety of presentations with ulcer, from small ulcers, multiple ulcers, much more extensive ulcerations, and you can see all of these things in your patients. Medical management will take away those risk factors that we talked about screening for pre-op. Make sure they're not smoking. It's probably the most common association I see in these patients is they've taken back their tobacco use. Make sure they're not taking non-steroidal medications, and definitely some of the longer-term loss to follow-up patients, this can be one of their precipitating factors. Treat them with a PPI twice a day. I like to add Carafate, that helps with any bile, and that's pretty easy to tolerate. I also add misoprostol for some of the cytoprotective effects, and try to make sure that they cut back on any stressors, alcohol use, and again, smoking. If they have H. pylori, I think it's also worth treating for that as well. If they have acute perforation, this is a different management strategy, and there's a variety of different techniques that can be used to be handled these. Sew a menum up with a patch, even sew a piece of jejunum up if you don't have enough healthy tissue. Do something with the remnant to help take care. They can put that on top as a patch. Sometimes a G-tube to help decompress. And also it's, I think, worth considering doing a truncal vagotomy in an acute situation to try to minimize further acid production. There are some endoscopic options available for managing perforations, either odor sewing or clips, but the tissue is not necessarily healthy, so these are not things that I would use routinely in my practice. If you have an ulcer that's past the acute phase where you're just treating the persistent symptoms, this is where if they've been on medication for a while, still are having an ulcer, what do you need to consider? There are a variety of different approaches that have been reported, and some of them with reasonable outcomes. Revision of the gastrojejunostomy is probably the most common. Vagotomy, either thoracoscopic or transabdominal, esophagojejunostomy, and conversion to sleeve. This is from Dr. Nguyen, a paper that he did talking about how you can revise these, and these are my strategies in terms of what I would recommend. I do think just resecting the gastrojejunostomy is good, but you do need to make sure you leave a very small gastric pouch. You do not want to leave excessive tissue there if you can avoid it. If you have a gastro-gastric fistula, I think it's also worthwhile to take out the whole portion of the stomach that's involved in that fistula to really minimize your chances for recurrence. Also, at the same time, the vagotomy can be helpful to minimize any acid production. Conversion to sleeve is, I think, a difficult procedure, but it is something that can be used in these patients. Basically, doing that anastomosis can reconnect the two portions of your stomach and help potentially deal with ulcer disease. And that's how that procedure would work with a new anastomosis. Some of the data here on marginal ulcer after Roux-en-Y, incidence varies between 1.7% up to 7%, but can be significant. Most of these can be managed medically, but reoperation is needed in up to 15%. Some of the larger series, 87% of patients required revision for marginal ulceration were able to be symptom-free after that revisional surgery. VATS can be successful, 8 to 11 patients in another series, and only case reports, which those were pictures from, for conversion from bypass to sleeve. So let's talk about some patients and what you might do for their management. So this is a young woman, had a gastric bypass, presenting about 18 months afterwards, having a little bit of epigastric pain. You do an endoscopy, and this is your finding. So this is the patient that you would start with the medications, and odds are that's going to be adequate therapy for them long term. This is also the patient you'll want to talk to about smoking and nonsteroidal use. This patient has a marginal ulcer and a gastro-gastric fistula. And this is somebody, depending on their weight loss, you may want to try medical management, or that might be somebody that you would consider doing a revision and excising that to move forward with better weight loss. This is a patient that had medical management of an ulcer and now has a recurrence. This is somebody that you're definitely going to want to consider for a surgical resection. If you've already revised them once with a gastric bypass revision, this might be somebody to consider for esophagojejunostomy. This is a patient that I saw in my practice, came to see me. She's 85, had a gastric bypass a long time ago, and she was having some funny abdominal complaints. And this is a giant gastro-gastric fistula, but there's no ulceration. You can see the retroflex view, the size of that fistula. She's fine, we just left her alone. So in summary, there's a lot of different ways that you might have presentation of a marginal ulcer or gastro-gastric fistula. I think prevention's key if you can effectively screen these patients, avoid smoking and nonsteroidal medications, make a small pouch, use absorbable suture. And medical management is definitely the first line, and for most patients, they'll be successful with that. If surgery is needed, first line is usually a gastrojejunostomy revision, but there are other options to consider. Thank you.